You can do the introduction through the slides.
Okay, fine, no
I'll
problem.
just welcome everybody and then, just kind of
No problem.
lay the
No
platform and you can introduce both Dr. Finch and Dr. Hoser.
Okay, perfect.
We are going live now.
Okay.
Parag, off to you, over to you.
So, good evening, everybody. We welcome you to this PKC webinar. We've been having this every Saturday, and also this Saturday we're having it. We apologize for a little bit of mix up with the timings. We had announced 7, but now it's 8 o'clock. I'm sure all of you are tuned in to an exciting evening, and we are very happy to have with us Dr. Christian Hoser and Professor Christian Fink. They need no introduction. They have been doing great work in ACLs, and especially today they're going to speak to us on the quadriceps tendon. Dr. Christian will speak on the quadriceps tendon harvest technique, and then we have the new gold by Professor Christian Fink, then the quadriceps tendon PCL by Dr. Sachin, who will give a talk on that, and then quadriceps tendon for MPFL reconstruction. I think it's the quadriceps tendon is something which we are all excited about, and we want to know more because we don't use it as much as it actually can be used. It has a great potential. So take you further, I want to request Dr. Sachin Tapaswi to introduce once again our elite speakers. Over to Sachin.
Thank you. Thank you, Parag. Can you hear me well now?
Very well.
Very audible. Okay. So friends, it gives me great pleasure to welcome you for this webinar. Apologies again for changing the 7 p.m. to 8 p.m. Actually, I think too much of isolation and too much of lockdown has affected our thinking capacity really. No, I'm just joking. So it's a great pleasure to welcome two great friends. These two are excellent friends for India. They have been with us previously on our previous editions of Pune knee course, and truly both of them are single-handedly responsible for pioneering the quadriceps tendon in various knee reconstructions. So welcome from the whole organizing team of Pune knee course, the new dates of which are 5, 6 and 7 November of this year. So Dr. Fink and Dr. Hoser, the two Christians, if I can say so, they come from this very lovely city of Innsbruck in Austria, and both of them are partners and run this very famous sports and injury prevention and arthritis center called as Gellenpunkt. So they would be very happy to welcome all of you to their center, which is in Innsbruck in Austria. And today's agenda will go through these 4 talks as I've outlined. And of course, please keep pouring your questions in as always. Dr. Christian Fink and Dr. Christian Hoser would be more than happy to share their experience and take care of most of any queries that we may have. So I'm going to stop my screen share now, and I'm going to turn it over to Dr. Christian Hoser for his first talk, wherein he's going to be discussing as to how do we harvest the perfect quad tendon graft. All yours, Dr. Christian Hoser. Thank you so very much for joining us.
May I start with saying thank you that you give us the option to be with you tonight, this evening. And we will try to present to you our experience with quadriceps tendon and how we learned to use it as our major graft, we have to say. Quadriceps tendon anatomy has been described long ago. It was a Swiss guy, Hans-Uli Stäubli, who described the length, the width, and the thickness of the quadriceps tendon. It was clear from there that the measures of the quadriceps tendon are absolutely appropriate for being used as a graft for several purposes. Now you see here their publication, another one by Seroganis from the US in 2013, where they confirmed what was already seen previously. Quadriceps tendon, as I said, was known as a great graft for the ACL and the PCL for reconstruction in primary and revision. But what always was for a lot of surgeons a problem was the harvest, which is difficult, and of course a cosmesis that is less attractive than especially compared to hamstring tendon. Now this is historically spoken or historically showed the classical longitudinal incision on the proximal pole of the patella, reaching proximal from there, with the tendon being cut out, you may say, or the graft being cut out of the quadriceps tendon. Now this leaves scars in beautiful young girls like this, which are not attractive, and this led Christian Fink, especially my friend, to the idea, let's find another way of harvesting this graft, this tendon, to be more appropriate for modern day use. Now, he with colleagues developed this technique. It's a transverse incision on the proximal pole of the patella, where we dissect down to the tendon itself. There is no fat tissue there, by the way, which is important even in people that are not super slim. You will not find any fat tissue between the skin and tendon there. And then we use this specially designed double knife as a first one, and the tendon separator as a second one, to cut out the appropriate width of the tendon that we need for the special purpose. Here in this photos, you see the double knife of 10 millimeters. There's options from 8 to 12. And you see the tendon separator, the one on the right, with a width of 5 millimeters, so that you get a graft of 10 millimeter width and 5 millimeter thickness out of the quadriceps. Then the third instrument, which was specially designed, was one to cut tendon proximally underneath the skin, which you can't reach this position, of course, other than with this tendon cutter. And the tendon cutter lets you reach into the tendon up to 110 millimeters. So you can really slide up your tendon cutter as far as you need. You don't need 110 millimeters for ACL and PCL, but for an MPFL and a bigger patient, you do want a longer graft. And then there's the first option that we show here, the quadriceps tendon with a bone block. You have to use an oscillating saw to harvest the bone block from the proximal patella, because the bone there is very hard. And if you are used to harvesting from the patella tendon, you know that harvesting there is also meticulous, but it's a little bit easier than even harvesting here, because the bone is harder here. So the oscillating saw is absolutely necessary. And as we show in this lower right picture, don't use the osteotome for these cuts. First cuts are not made with an osteotome. You will split the patella. The third cut, which has to be made in the back, this is now the next option to use the quadriceps tendon without the bone block. There, it's technically easier to harvest it, and you see that we use a part of the tendon that is also already overlying the patella, which is shown here. And in the next picture, you see why we do this, because we like to flip around this periostral part of the quadriceps tendon like this, hold it in, and then be able to make a nice leading edge of the graft that slides in easily into the tunnel you will prepare. Now, this is an arthroscopic, or using the endoscope, to show what the defect looks like. You see the floor of the defect, you see the side wall of the defect, and you also see here that we do not cut into the joint. I would say that in about 70 to 80% of all cases, we do not open the joint at all. In 20 to 30% of the cases, you do open the joint. But if you close it nicely like you see here, you will not have a problem with creating pressure in the joint and doing a normal arthroscopy, a normal ACL reconstruction after that. Now, why is this shape of the graft that I have shown to you now something that has been very intriguing to us? Robert Migelski from Warsaw has shown us a very new and nice concept of anatomy of the ACL. And he, as you may already know, has shown us that the ACL is not a round structure, but seems to be a ribbon-like, very flat structure. Now, if we look at this origin from the femur, we see that using a flat tendon to reconstruct this flat ACL does make sense. So that's something that we developed and we are using regularly in our patients. A round graft created out of this bone block, graft created out of this bone block has certain differences. Number one, the square diameter of a 7 millimeter round graft is equal to a square diameter of an 8 by 5 millimeter rectangular graft with 40 millimeters squared. We have shown here the measures that can be compared between round and rectangular. What does the shape of the graft, meaning a rectangular graft, do in motion? And you see that the fibers of 0 degree of knee flexion is a parallel one, which is actually the one that the ACL has. And it twists like it should twist, or like the ACL, the natural ACL does twist when we flex the knee to 135 degrees. This looks very nice, and we think that the advantage is there, and we have shown that it can even be measured. Now, another aspect which is important to us is the diffusion length in a graft that is round as opposed to a graft that is rectangular is massively different. It's minus less than 40, about half the distance in a rectangular graft, a round graft. And this does play a role in the biology of the graft, how it is nourished, how it can grow in, how it can be biologically incorporated. But that's another advantage that we think is present with a. Now we show you a video that gives you an impression how we do this harvest and the ACL reconstruction. As I have alluded already, our goal is to make angular very close to nature ACL graft, which twists in knee flexion. See now in a cadaver, a harvest situation with a transverse incision on the proximal pole of the patella. Then we use the double knife as the first knife to make 10 millimeter, two cuts separated 10 millimeters that creates the first separation of the tendon. You see the length gauge on the handle. Then the second knife is a tendon separator, in this situation 5 millimeters thick. That is inserted like this. Pushed proximally, we should push to the surface of the tendon, meaning back, and then the tendon cutter is inserted, pushed proximally. And then the graft can be pulled out subcutaneously, and the dissection can be followed on to the patella. Now here it is shown how to use the oscillating saw for the three cuts that I have alluded to, or to use the knife to dissect this periosteal part of the extensor apparatus, say the following fibers of the quadriceps tendon above the patella, which makes it possible to fold it in like this and create a nice leading edge for the graft. Now then we close the tendon defect, which creates the surface of the tendon which has the potential to regenerate fully. Now this is the intra-articular situation where we have put in our guide pin on the femur, and we engage the 4.5 millimeter drill intra-articularly, drill a 4.5 millimeter hole, and then we use these rasps with 8 by 5 millimeters or 9 by 5 millimeters to create this rectangular shaped tunnel on the origin of the ACL in the femur, driven into 20-25 millimeters. Studied it even a little more here. Then we use a dilator, which dilates the tunnel to the appropriate size. And a very similar thing we do on the tibia with a guide pin first and a second guide pin, which is anterior to the first one, which should mimic the insertion area of the ACL on the tibia. And then we use the same instruments as on the femur to create a rectangular tunnel on the tibia as well. Now this is the graft. You see here the version with a bone block, a flat bone block, 9 by 5 millimeters with the endo button attached to it. And now already the intra-articular situation. Here, of course, you have to take care that the bone block has to be orientated or rotated in the correct way so that it can slide into the proximal tunnel nicely as it is slid in now. Again, what we think is a big advantage for the ACL reconstruction as we do it. Now here you see a picture from a living patient with the ACL graft in place. It engages in the intra-articular notch. It is coming down from the femoral insertion. The next picture shows you a graft which shows a nice synovialization 6 months after surgery. And it looks like a biologically nicely incorporated graft. Now there is another advantage of this technique in situations where the revision comes into play. You see here how small the defect or the tunnel is in the femur compared round to rectangular. Here you see a clinical result of a patient with harvest of the quadriceps tendon and a postoperative clinical result in both maximum flexion and extension. And another option for the quadriceps tendon is the pediatric ACL. We have these very small young patients with functional instability of the knee. We're always wary of what we should do to them, but quite a few of them need a reconstruction. Not happy unreconstructed. Here, the technique is shown where in this little patient, the transverse incision is performed and the tendon is harvested the same way as in an adult patient. And here, of course, we do a graft without a bone block, bring it in trans-epiphyseally in a technique that shows on the X-ray like this to reconstruct the ACL in the pediatric. Now the revision ACL, where the big advantage of the smaller dimension of the rectangular would be very tricky to place a round tunnel posterior to this wrongly placed tunnel in this position. But with this rectangular situation, rectangular bone tunnel, it is very often possible to do a single stage revision safely and get a firm grip of the graft on the femur, whereas with a round tunnel, we would probably opt for a two-stage revision and fill up the round bone tunnel from the primary operation first and do it in a second stage. Clinical picture intraoperatively, the rectangular tunnel behind the previous round tunnel, and on CT, the rectangular tunnel behind the previous round. That's actually how we started with quadriceps tendon and how we felt that this is a good graft. More than only a revision situation. Now, in conclusion, I may say that the quadriceps tendon is a reliable technique for ACL reconstruction, primary and revision situations. It has a low harvest site morbidity and shows good clinical results. And it has two options, the bone block and the soft tissue. Here you see the publication. Here you see a nice group, small group of people from all around the world, I may say. The International Quadriceps Tendon Interest Group that had its first meeting in Innsbruck and was supposed to have its second meeting in these days in Oslo. It had to be postponed for reasons that we know. The website of the IQTI. Thank you for your attention.
Thank you, Christian. That was a really nice presentation. We actually lost your voice a couple of times. So any questions from the panel and any questions coming from the participants, more than welcome.
There's one question which has come up, Sachin.
Yes.
So, Dr. Finch, excellent talk. The incision which you showed was a transverse incision. So the question is, why not take a vertical incision which will actually show you more part of the tendon as well as more of the patella? So why a transverse incision and why not vertical?
One word.
Sorry, we could hear you.
So the main reason for doing it transverse is a cosmetical reason.
Okay, so any disadvantage by doing a vertical incision?
We think that there's a major difference. It's a major difference.
No,
now, if you have a revision patient does not care about his incision. A revision patient wants a stable knee, but a primary patient does care about his cosmesis of his incision. So we think the acceptance is much higher than with longitudinal incision in our hands.
Okay, there's another question that's come up. When you harvest a bone block for a primary ACL, correct? So do we take the bone block to the femur or to the tibia? And if so, why?
We use the bone block on the femoral side nearly all of the times. There has been some situations where we would use the bone block on the tibial side if there was a bone defect in a situation where we would do a revision and we would like to fill up a bigger bone tunnel on the tibia and have an easier situation on the femur where it does not need a bone. So then you can reverse it. But most of the times we use the bone block on the top, meaning on the femur.
Okay. Dr. Anshu has a question. Anshu, can you come in with the question, please?
Yeah. So my question is, what are the conditions or scenarios where you would not harvest a QT? Size of the patient, size of the tendon on MR. What are the situations where you would not choose a QT?
We do not measure the tendon pre-op on MR. We are very happy with the situations, meaning with a volume that we can get from the patients. What can happen is if you have a thin quadriceps tendon to start with, that you do take a full thickness graft, which is what most surgeons do anyway when they do an open harvest. So we do have some patients where we do get a full thickness graft when it's thin, but we are not aware of that we don't get a sufficient graft at all. Certainly things happen when you do a bad job and you don't harvest the proper graft. It does happen very rarely, but it does. Then you would have to go to another graft source on the knee, but that's very rare. It's a very reliable source of graft in our hands. But there is situations where we are hesitative of harvesting. That is a bipartite patella, where we would not harvest the bone, but still would harvest the tendinous part of the quadriceps tendon. Let me think if there's other situations where we are sort of not in male patients at the age of 60, 65, where we do have some that need an ACL reconstruction. Those are the ones that rupture the quadriceps tendon. As we know from the clinical setting, there we think about harvesting the tendon sometimes. If they're a little heavier, then we would not harvest the tendon from there, because if he has a quadriceps tendon, one may say, okay, you have you should know that they are prone to rupturing the quadriceps tendon anyway.
Okay, so Dr. Nilesh has a question. Nilesh, can you come in with your question, please?
Right. So what I wanted to ask is that when to get the maximum length of the quadriceps tendon, would you like to err on the lateral side or the medial side when you're harvesting the tendon?
Absolutely important question. Err to the lateral side. So in the studies that have, they say you should be at 61.5% from medial to lateral. So a little bit more lateral than central when you want.
I think the audio is switched.
When we do not need super long.
Yes, Ashok.
A long graft.
Yeah, Christian, 1 second. Yeah, can you just change the audio? Yeah.
Is that better?
Yeah, that's much better.
That's perfect. Yeah.
When you do not need a super long graft, then you just orient yourself on the fibers of the vastus medialis entering the quadriceps tendon. So you look in, you see where the vastus medialis fibers enter, and that's your medial cut. And then your lateral cut is determined by that.
Right.
If you need a graft that is very long, as I've alluded to in the MPFL situation, you do need that. You really look in and you follow the fibers of the rectus femoris, which are the longest ones, obviously.
Yes.
And then you incise with a double knife exactly where these fibers are visible, leading very far proximal.
All right.
Okay. So there are a couple of questions which are also coming on, what is the incidence of weakness of the quadriceps after having harvested the quad tendon. So I'm not so sure whether Professor Fink is going to cover that in his talk, or would you be happy to answer it right now?
I think he will. Did I understand correctly? If there is a weakness in the tendon.
No. Sorry. My bad. If we harvest the quadriceps tendon, are we likely to cause weakness in the quadriceps post-operatively, post-harvest?
He will allude to that in his talk.
Perfect. So now there's Dr. Sandeep Biraris wants to ask a question. Sandeep, can you come in with a question, please? And then maybe we'll take further questions after Professor Fink's talk. Sandeep, please come in with a question.
Yeah. Professor Fink, in revision cases of ACL, what type of fixation is preferred on femoral side?
We are using extracortical fixation in every single case.
Perfect. Okay.
Thank you.
Thank you, Dr. Hoser. We'll move on to the next talk now. We have almost about 25 odd questions coming up concerning the quad tendon and the ACL. So once we finish with Professor Fink's talk, we'll take all these questions again.
Welcome from my side. We just switch 1 second. Okay. So welcome to India. So I will talk a little bit on the different graft sources we have, and maybe the situation, which graft is for which patient. So these are my disclosures. I get product royalties from Karl Storz for developing this instrumentation. When we look at the evolution of ACL reconstruction, we have these different graft options. And when we started our training in the 90s, patellar tendon was by far the most common transplant. And then in about 2000, the hamstring came along. And then slowly seeing some issues with the hamstring, there was discussion about higher re-rupture rate. And then in about 2000, at least in Europe, quad tendon came along and was used more and more. This is actually very well represented in the literature when you look over the last years, that the amount of quad tendons publications have been increased by every year. So now I'd like to compare the different grafts for different parameters. And I will start with biomechanics, the different grafts, meaning patellar tendon, hamstring, and quad tendon. And when it comes to biomechanics at time 0,
all the graft sources we use, we can see they approximate or almost supersede the natural ACL. So there's no real advantage of any of the graft when we look at pure strength at time 0. When we look at graft incorporation, we can see that bone incorporates faster than soft tissue. And we know from patellar tendon that this is definitely an advantage of this tendon. When you have a bone block on the end, you've got a quicker graft incorporation. So this is an advantage for any bone graft, which you can, since you can use the quad tendon with the bone block, this is definitely an advantage over the hamstrings, for example. When we look at laxity and compare different studies, relation of the pivot shift or the Lachman test, where are different studies, huge systematic reviews. And here in this study from 2019 by Jacques Menetre, you see there is no difference, no significant difference with respect to the Lachman test between hamstring, quad tendon, and BTB. When we look at the pivot shift, again in this study, no significant difference between the grafts. However, there are some other studies. Again, this is a systematic review showing there is some difference. There are more negative Lachman tests in the quad tendon groups compared to the hamstring groups. Pivot shift is about similar. So there is some evidence that maybe patellar tendon as well as quad tendon have a slight advantage over the hamstrings when it comes to laxity. So if you look at this in the comparative grafts, maybe there's a slight advantage of these two grafts over the hamstring compared to laxity. Thigh strength, this is also an interesting aspect. See here in this multi-center study, 3 out of 7 studies found a significant weakening of the hamstrings after you harvest the hamstring graft. So this is some other studies did not find this, but 3 studies found the pure testing on flexion. We know if you harvest a hamstring, if you would test internal rotation, there would be a side-to-side difference because these are the main internal rotators. So there may be a strength difference. When we compare quad tendon versus hamstring with respect to muscle recovery, in the end, there is no difference between those groups. We looked at a study on our patients, and you can see when you harvest the quad tendon that, of course, the extensor strength is impaired initially, but then it's coming up and it can recover fully. Whereas, as we know, when you miss the hamstrings, you might not recover fully, but you can, even after a quad tendon harvest, you can fully recover your strength, and it's a matter of training, and it's not as a matter of the graft harvesting. So its full recovery is possible. So from the strength part, I think there is an advantage of patellar tendon and quad because we know that even if it's maybe hard and training is hard, you can fully recover it. Whereas if you lose a muscle, you might not recover flexor strength or internal rotator strength fully. When we look at subjective outcome with respect to PROMs, comparing the different graphs, there is absolutely no difference in this big series. So there's no difference between patellar tendon and hamstring and quad tendon in almost none of the studies, also in our studies. So you see no difference, no significant difference with respect to PROMs. So subjectively, they're all about very, very similar. When we look at donor side morbidity, there's definitely a downside of BTB represented in almost all the studies. So BTB being a great graft with great strength, it has more morbidity compared to either hamstring or quad tendon. When we look at anterior knee pain and kneeling pain especially, so if you have a kneeling occupation, patellar tendon is definitely not the graft choice, whereas you can very safely use hamstring or use a quad tendon graft for this patient group. So from morbidity, we think there is an advantage, or there's one really disadvantage of the patellar tendon graft. When it comes to cosmesis, we were talking about this. It has been a downside for a long time to make this big incision superior in the thigh, and also patellar tendon may have some disadvantage cosmetically compared to a hamstring graft. And as you say, in a primary situation, cosmesis, we think, do play a role. But as we said, you can harvest it through minimal invasive ways. Even the patella tendon, you can theoretically harvest with a small incision or 2 transverse incision. And we see the transverse incision, they really heal very nicely here on the tibia. So there is definitely let's say, maybe a slight disadvantage of the patella tendon with respect to cosmesis, but not for the other grafts. Arthrosis, I think this is an interesting fact. And here we have to say that we do not have the same amount of long-term data for quad tendon. When we compare patella tendon to hamstrings, there seems to be an advantage of the hamstrings with respect to a lower rate of development of arthrosis in these patients. Re-rupture rates, and this I think is a very important fact when you look at our patients, is not just the subjective outcome, also the risk of re-rupture. And when you pool different studies again, this is the average re-rupture rate of an average population. So we see patella tendon and quad tendon about similar, hamstring tendon just a little bit higher. There was a very concerning study showing exactly the opposite, which came out recently from Denmark, from Martin Lind, from a registry data. And in his registry data, opposite to all the published information before, quad tendon had a higher re-rupture rate compared to patella tendon and even compared to hamstrings. When Martin Lind looked at this more closely, they could actually find out that the reason was they had 4 centers, and the high revision rates in the registry came out of 4 centers which had revision rates of 10 to 20%, and it was for 4 centers of very low volume surgeons. So in the high volume departments, they do greater than 100 procedures of reconstruction a year. They actually saw that the revision rate was lower compared to all the other grafts. So you have to be careful with registry data and look at them very carefully. They can see that it is a matter of, there is a learning curve for sure. And I think as in any procedure, you have to do a few to get a good result. Our practice, when you look over the years, we started out with mostly hamstrings and then increased patella tendon for our primaries and also increased the volume of ACLs accordingly. We do about 300 ACLs, and you see that quad tendon became the #1 clearly in 2017 and now going on 2019. When we look at our own graft and our revision rates, and this is a study which was just accepted 2 weeks ago in American Journal of Sports Medicine, it will come out soon. Again, if you look at the overall revision rates, and this is comparing data from our database of 800 patients, 200 hamstrings, 200 quad tendons, and about 650 hamstrings, you see that the overall revision rate of the is about 4.3, quad tendon 2.8, hamstrings 4.9. The contralateral revision, contralateral rupture rate, which I think is very important because that tells you that your patient really went back to sports, went back to their activity. It's about 2.3 in both of these groups. But when you look at high active patients, and these are patients of a technical activity level greater than 6, then you see suddenly a difference between the two grafts, and you get a significantly higher revision rate of the hamstrings compared to the quad tendon when you increase the activity of the patient. So here, just in comparison, this is the quad tendon in high active patients compared to quad tendon in less active patients. And same in hamstrings. If you have high active patients, you have a significantly higher revision rate here compared to the contralateral side, whereas as soon as you lower your activity, graft does not matter as much as it has been before. So re-rupture rate, we maybe have a slight advantage of the patella tendon and quad tendon. So if we zoom up, we have a very close run up, and we see that quad tendon for sure has its standing compared to the other graft, and maybe for some patient has some advantages. One graft, as we know, may not fit for all patient situations. So there are patients who benefit from one or the other graft. And I think what we have to do is an individualized type of surgery to really take all the aspects in account. So if you have this patient, a young female athlete with valgus alignment in a high-risk sport, 16 years is probably the highest risk patient. If you want to do a patellar tendon, well, the morbidity in this girl is certainly high. A hamstring, if you see this valgus alignment, you would not necessarily like to take. So here, I think a quad tendon is a very good solution. So in summary, is it the new gold standard? I do not know, but we do know that it has good anatomical, biomechanical, and clinical, as well as cosmetical outcomes. We do not have the long-term data which we have for the other graft, and we know that not every graft fits for every patient. As a knee surgeon, I think we have to be familiar with all the grafts available. Again, IQTI, if you're interested, go to this website, you find everything what's written on quad tendon. Thank you very much.
Thank you, Christian. That was really great. And we have a couple of questions coming up again. So when we're using the quad tendon graft for primary ACL, and you've harvested the bone plug, so why do we use suspensory fixation on the femur? Why can't we use just an interference screw on the femur? Any specific reason why?
First of all, of course, you can use a screw if you like to use a screw in your patients. I stopped using screws intraarticularly a long time ago, and it was because at one situation I cut a graft when I put in the screw, and this put an end to my usage of interference screws intraarticularly. But if you're familiar with it, and if you harvest it with a bone block, or even as a soft tissue graft, if you're happy with screw fixation, of course you can use a screw fixation for the quad tendon as well. But that's personal preference.
Okay, Nilesh, you have a question here? You need to unmute yourself, Nilesh, please.
Apologies. So, Professor, what I wanted to know here is, in a revision setting, if the prior surgery has been done with a BTB graft, are we safe enough to harvest the CQT with a bone plug? That is my first question. And my second question is, in a multi-leg setting, are we at a higher risk of the extensor mechanism disrupting if you're harvesting a CQT along with the BTB in the same sitting?
First of all, yes, you should be careful if there has been a pre-harvest of a bone block of the patella. I like to do a CT scan. Most of the time, you can always use quad tendon as a soft tissue graft. Right. And if there's a big enough bridge, I think I have done it, you can also use a bone block from the patella, but you have to be very careful. And I like to see a CT scan. And in case I am in doubt, I either use a soft tissue graft or I go to the contralateral side.
Right.
In multi-leg surgery to harvest, actually, I think I have never done it, to harvest the patellar tendon and the quad tendon on the same knee for a multi-leg situation. I think so far I have never done this. I just, in this case, I harvest the quad tendon from the contralateral side if I need it.
Right. Yeah. Thank you.
Okay, so there were a lot of questions on after harvesting a quad tendon graft, do you have to modify your rehab program, and are you at risk of getting weakness of the quads post quad tendon harvest?
In fact, I mean, the most important, I think, after any ACL reconstruction is to focus on active extension to get the quad firing patterns back. We have patients, even if you harvest a hamstring, they have a tough time to fire their quads. But if you focus on extension and quad activation, we do not see a problem. Actually, they do have pain for the first 2-3 days, but the harvest site morbidity is extremely low, and even compared to hamstring, it's extremely low. So we do not see the problem. We see that when you measure strength, you see that, in fact, it takes a little bit longer for the quad strength to recover compared to hamstrings. But actually what you get is a higher hamstring to quad ratio, which we think may be beneficial for the initial parts of rehabilitation. So you have your hamstrings are protective and they're firing at full force. And the quad is a little bit impaired, but it comes back later. But the most important is, I think, in starting from immediate post-op, you have to focus on extension and quad firing patterns. That's the key.
Okay, the next question is that when we harvest a quad tendon graft for a primary ACL, do you harvest the full thickness of the tendon or do you harvest only the partial thickness of the tendon?
Yeah, we as I say, we try to harvest a partial thickness graft. As Christian said before, sometimes it happens that you can actually go all the way through, especially if you have got a thin tendon in a maybe tiny person, which we do not think is a problem, but we aim to just leave a small layer of a quad tendon in the center and in the center there. This is the ideal situation, and we always close the harvest site defect.
So what happens if the joint gets open and the fluid leaks out? I mean, what happens if you need to sort of close the arthrotomy formally? Will that lead to any problems?
No, you can actually close it very well. Even if you use a small incision, you have to use a long Langenbeck retractor. You have to use a small needle, and you can really close the defect up all the way. And then what we do is actually we take a swab and basically we put the tamponade in the incision. So we just put a swab in the incision to tamponade the bleeding for one thing, but also you can tamponade some leakage if you have. But it's so far over where we are overlooking now about 700 quad tendon reconstructions, and we hadn't had to stop one because of a leakage problem.
Okay, so can we use a normal dilator for the femoral drill, for the femoral tunnel, or is it necessary to make it rectangular, or can we just use it like a round circle?
No. It's absolutely not necessary. You can do a round tunnel. It's just the flat maybe has some advantages in a revision situation, but you can absolutely use a round tunnels. So that is not a problem. You don't have to change your technique when you start using quadriceps tendon.
Yeah. So to all the viewers, you can keep pouring your questions in. I'm probably going to take a couple of questions more before we move on to the next talk. The next question that's come up is that what is the infection rate after doing a quad tendon harvest? Is it any different from hamstrings or bone tendon both?
Well, what I can tell is I think the biggest change in infection rate came through the usage of vancomycin. So to wrap your graft into vancomycin really reduces your infection rate almost to zero. And I think this is regardless of the graft. So we do not see more infections with the graft. And I have to say, since we use vancomycin, our infection rate from which was below 1% went almost down to zero.
Okay. The next question is that if you're doing a concomitant ACL with PCL, where would your quad tendon graft go to? Would it go to the PCL or would it go to the ACL?
I think you can do it both ways. For me, it would go to the PCL. I think it's the stronger graft, and I would try to put the stronger graft to the PCL in this case.
Okay, and if some of the graft remains open, in the sense you've closed the arthrotomy, but at the apex proximally, a small area still stays open, will it cause any weakness?
No, we have not seen it. I have seen a picture of a friend of mine who took a very long graft in a short patient, and he actually went into the rectus muscle and he got some retraction there. As you see it in a muscle rupture, I would say, we know that you cannot, even in a big muscle ruptures in soccer players, if you have this situation, it doesn't look nice cosmetically, but it does not in fact weaken the muscle if you train. So it can compensate. But this only happens, and I've seen it once, only happens when you go very far up and go into the muscle in the rectus muscle insertion, it can retract.
Okay, so I think Parag, should we go on to the next talk, because there are, I think, about another couple of questions that have come up. I'll just quickly ask one while Dr. Fink stops his screen sharing and I put up my screen up. So do you need to use, what happens if you use a tourniquet during harvesting? Does it cause any problems?
Sorry, can you?
if we use a tourniquet,
Yeah.
will it cause any problems because the quadriceps will get impaled in the same?
No, we always, in fact, we always use a tourniquet, so we haven't seen any problems. So we do our reconstructions with tourniquets. So no.
Okay. Right. So we'll move on to the third talk. I'll be speaking on the role of the quad tendon for PCL reconstructions. And I think it's really important for us to quickly look at the anatomy of the PCL, because that's where the importance of this very beautiful graft comes into play. So the PCL femoral footprint is a large footprint. As we all are aware, the footprint extends from the roof of the nosh. It's flush with the articular surface, and the length of the PCL footprint in the average Indian male is close to anywhere between 25 to 30 millimeters in length. The posterior extent of the PCL is variable. It extends up to 7 o'clock in the left knee and up to 5 o'clock in the right knee, which means that on the femoral side, you require a very large sort of footprint of collagen if you want to reconstruct all the PCL fibers adequately. So I think this is one of the most important take-home messages when we are planning to do any form of PCL surgery. On the other hand, if we look at the tibial side is a sort of a small concentrated insertion point, which is in a small depression, which is below the tibial plateau and is almost about a centimeter below the joint line, as what you can see from this arthroscopic demonstration here, where the scope is in the posterolateral portal and the Wissinger rod is coming through the posteromedial portal, which is showing the insertion point of the PCL. So the ideal graft for a PCL reconstruction has always been a matter of debate. But what is really important is that when we're doing PCL surgery, you will require a longer graft, which is very important because the intra-articular length of the PCL is in excess of 38 millimeters. So a smaller length graft will not suffice. You need a graft that will pass with ease because you have to negotiate the killer turn, so as to say, and that's another important point that we need to take into consideration. You need to have a graft that is going to be able to place a large amount of collagen within the footprint, which is again an important aspect. You need a graft that has to be very strong. It should not stretch out over a period of time, and it should allow good, strong fixation, which is also very important. And last but not the least, you need the graft to allow you a double bundle construct, if at all you need to do one, and you need a graft which needs to have a large cross-sectional area. So the demands for a graft for the PCL are way far more than what the demands are for a graft for an ACL surgery, which is the more important point that we need to understand. So what are the different graft sources that we use for the PCL? The hamstrings are used widely. They will give you good length, but they're unable to give you good diameter graft, which is very important if we need to have good cross-sectional area and if we need to place more collagen. The plus point with the hamstrings graft is that you take out the PCL agonist, so that probably could go into favor, but very frequently to get good quality collagen and good quantity collagen, we probably need to do a contralateral harvest as well, which may not be appealing for a lot of our patients. The bone tendon bone graft probably is best suited for the inlay technique, but it's a slightly shorter graft, and to try and get two bone plugs to negotiate these killer turns becomes a bit of a pain. And of course, you know, when you're doing such form of BTB surgery, it may not be the best way to sort of go around, and you're risking weakening of the extensor apparatus. The quad tendon graft, I feel, is probably best suited in these instances, especially for PCL surgery, because as what has been demonstrated, the morbidity of harvest is minimum. It allows you a double bundle construct. It is long, it is strong, but the only disadvantage or the limitation would be to learn the harvest technique, which has been demonstrated very elegantly in the first talk. So how do you harvest, or how do you prepare it? So that's a quad tendon graft that has been harvested along with a bone plug. You need the length of the bone plug to be about 30 millimeters, which is what I choose. You make 3 holes and pass 3 number 5 Ticron sutures. I would then go ahead and split the quad tendon graft straight down into 2 limbs. normally would like to take 60% on one side and 40% on the other side, take some strong number 2 suture, make whip stitches to a distance of about 30 millimeters on both sides, size them, and this is how I would then prepare a double bundle quad construct. So as you can see here, my bone plug is almost about 11 millimeters, which allows me to have a thick, robust graft, which is going to allow me to do a double bundle as well as which is going to give me a good construct. So here we are pulling the 2 bundles of my quad tendon graft in the 2 sockets that we've drilled. It's important to respect the fiber orientation at this instance. You want to have the AL fibers running on top of the PM fibers. And last but not the least, you want to first go ahead and fix your bone plug in the tibial tunnel. This is looking at it from a posterolateral portal. I want to see the tip of my guide wire come out, and my bone block should be flush to the mouth of the tunnel posteriorly, where I can very nicely put in a screw, and then this is what my final construct should be. So that's a concomitant ACL PCL reconstruction, and what I've just demonstrated here is to how we will go ahead and construction. The role of using the quad tendon autograft and the allograft has been well described. The Achilles allograft, which seems to be the more popular for doing a PCL surgery, is comparable to that of a quad autograft. And another study which looked at a comparative prospective study in which they compared double bundle quad graft in one group to a semi-T plus a quad in the other group showed that the quad double bundle has got equivocal results. The group from Taiwan probably popularized the role of quad tendon graft in PCL surgery way back in 2000, and they first described their technique initially for the same, and then later on they went and published that they had good outcomes when they compared their technique with a quad tendon graft with that of a 4-strand hamstring graft as well, with similar outcomes as regards IKDC, thigh girth, stability, as well as Tegner score. They came back later after about 4 years and published a long-term follow-up on the same, but now they found that the same group which was comparable 2 years ago was now showing better results statistically in the quad tendon bone graft with lesser thigh wasting, better stability. The hamstrings knee tended to get more lax over a period of time, and they had better IKDC scores. A recent update published about 2 years ago, basically based on graft considerations in PCL surgery, also demonstrated the same. They concluded that though the Achilles tendon allograft remains to be the graft of choice while dealing with PCL tears, in countries which don't have good access to allografts, the quad tendon with bone autograft was probably the most favored outcome. So to conclude, I think it's important to understand that choice of graft plays a huge role, especially when we're looking at PCL surgery. You need your graft to be long, strong, and durable. It needs to have good cross-sectional area. Hamstrings graft do have a concern with late laxity, and the possibility of doing a double bundle becomes a huge advantage when we are looking at the same. So this is in a brief nutshell as to what the PCL has to offer us. And Parag, you have any questions on your end from the participants and the attendees?
Yes.
And if Aru has any questions, please do come forth.
So that was an excellent talk, Sachin. Very well you've covered the role of quadriceps tendon graft for PCL. The question which has come is that do you always do a double bundle, 2-tunnel double bundle PCL, like on the femoral side you put 2 tunnels, or it depends on the situation?
So I think it depends upon the indication, Parag. So if we have someone who's got an isolated grade 3 PCL or a grade 3 PCL with a posterolateral corner tear, then I would like to do a double bundle. For someone who's got an MCL with a PCL or someone who's got a knee dislocation with ACL PCL, I would probably just do a single bundle PCL in those particular patients.
And your bone plug always goes in the tibial side?
Yeah, my bone plug is always to.
Okay. Any Aru, you have a question?
Yeah.
Yes, Aru.
Excellent talk. Have you used peroneus longus for your PCLs?
I think we have lost Tapasvi sir for a moment.
Yeah, so the question is on peroneus longus. So can I ask
He's back.
Dr. Yeah.
Yeah.
Sachin, you got the question?
No, I didn't get the question. Sorry.
Aru, you can ask again.
Yeah, Sachin, have an excellent talk as usual. And have you used peroneus longus for a PCL? Now you have a good lab. You can have a good lab.
So, yeah. So, Aru, I think the answer to that is that I have used a triple strand, sort of a three-folded peroneus longus as an all-inside technique for the PCL. It seems to be promising, but I don't think that's going to be my first graft choice if I have to do a PCL reconstruction. If I'm forced to use it because there's not much availability of grafts in a multi-leg, I may be using it, but that probably would not be my first choice of graft.
So Dr. Hoser and Dr. Finch, do you have any thoughts on the peroneus longus? Dr. Hoser?
I've heard about it and I've read about it, but I've never done it.
Yeah.
I think two laptops are together, and that's why we have having echo.
Okay.
I have no clinical experience with it.
Any other questions for Sachin?
Parag, there is another question that's come up here.
Yeah.
The question that's come up on the chat is that again to Dr. Fink and Dr. Hoser, and the question is that what is the learning? Oh, I think we're getting an echo there. Yeah. So what is the learning curve for performing a minimal invasive harvest? So how many cases do you need to do confidently before you're able to do this minimal invasive harvest technique?
I think the most important is to make when you start using this instrumentation, you should use a long vertical incision, a normal incision, and then see what you're doing with the instruments. And then when you're comfortable with the instruments, then it's very easy to do.
Okay.
But you have to see first.
Okay. I think it'll be nice if you go back to your headset. Yeah, that's lovely. Thank you. So I think probably the Christian Hoser's phone was giving some feedback, maybe. I don't know.
Yeah.
Okay. Any more questions from Nilesh, Anshu, anybody? If not, I think then we'll go to the next talk in which Dr. Christian Fink will discuss how he uses the quad tendon graft in an MPFL reconstruction.
Just 1 second. Okay. Okay, so these are my conflict of interest again. Well, many reconstruction techniques have been published, and at least in Europe, it was predominantly with using hamstrings with different fixation techniques. And then in 2012, this paper by Jay Saar really showed that despite giving some really good clinical results, we have seen some significant complications in this series, and the complications were associated with this procedure were like patellar fractures due to implants, and then stiffness due to a very stiff construct. And for the first time in 2008, I was on a conference in Macedonia, and I saw this presentation by Matjaž Veselko from Slovenia, and he presented this quadriceps tendon technique with the strip of quadriceps tendon. And this was very intriguing to me because, as I said, the construct looks more like an MPFL when you look at it anatomically. So the flat strip of quad tendon was really very similar. And during this time, we were just working on developing this instrumentation for ACL and PCL harvest, and all basically we had to do is just make a knife that is a little bit thinner, but use the same instrumentation, but with a little bit thinner strip of quad tendon. And then, of course, I went to the literature when I came home, and I looked at it, and so this has been published before by Rob Steenson from the US, and I think it has a really big publication coming directly from India. So it must be used very commonly in India. And this was published by Deepak Goyal, and they are using it quite successfully. And I mean, there's only, to me, for this technique, as I saw it, was only this downside, especially you have the female with soft tissue and maybe a little bit hyperextension, and they develop these huge scars. And if you have a scar like this compared to a hamstring, this is not really attractive. And again, we try to solve this problem with this instrumentation. So as I showed, we use basically the same double knife. Mostly it's a 12 millimeter width, and then you use just a tendon separator, and the thickness is 3 millimeters compared to the 5 millimeter or 6 millimeter for the ACL PCL. It's just a 3 millimeter strip of tendon. Then you use it longer, of course. You need about the 10 centimeter strip of tendon, which is fairly easy to get from the rectus tendon. Then the graft is fixed on the end with resorbable sutures, and then it's like for the ACL graft, as we like to use a strip of periosteum. Same way you use a strip of periosteum, you prepare down about 1.5 centimeter on the lateral side and about 0.5 centimeter on the medial side, and then you undermine the tissue on the medial side of the patella. It's very important to start centrally. Don't start the harvesting procedure medially, because then you have no tissue to suture it to. So start centrally, and then you can diverge it underneath this tendon sheet and fix it on the edge of the patella with 2 sutures. When we use the image intensifier, as you're used to, for positioning the femoral tunnel, and you can fix it on the femur with a resorbable screw, or like we like to use it in children, where we fix it with 1 bone anchor distal to the physis. In children, it's very important to, when you use the image intensifier, to look in 2 planes, because the physis is going upwards on the lateral view. So it looks like you might be above the physis, but if you look at AP, you're always slightly distal to the physis, and this is important, and you should aim your anchor or your guide pin distally, and we recommend use an anchor instead of a bone screw. So here is the video showing the whole procedure. You see it's a slightly transverse incision, about 3 centimeters on the supermedial part of the patella. We like to do an arthroscopy before to evaluate the gliding of a tendon. I like to use a superlateral approach. Gives you a very nice view of the patellofemoral joint, and you see the huge dislocation to the lateral side. Then you make your incision. Pretty similar to your harvest of the ACL PCL graft, where you make your incision more centrally. This is slightly superlateral. Exposure is very important to incise all the bursal tissue to give you great exposure of the tendon. So as long as you see transverse fibers, you know it's not the quad tendon. It's always it's a bursal sheet, or it's some fascial sheet. Then again, you use the double knife. It's very important when you use this knife that you flex the knee over 90 degrees, so you've got good tension on the tendon. That is very important for the cutting procedure. So sometimes when you'd like to demonstrate this on a cadaver which is cut on the femur, you have no tension, and then it's difficult. When you use these knives, you really have to get tension on the quad tendon. And here you see the length For an MPFL, you like to have about 10 centimeters above the top of the patella. 9 is a minimum, depending on the size of the patient. When you use the tendon separator, and here it's the 3 millimeter separator in this case, otherwise it's the same instrumentation. It's been slided in from the side, where you can extend the knee a little bit. It's easier to insert it. And then when you start to cut, it's important that you have full tension on the quad tendon again. Very important here to be central, maybe even slightly lateral. We get the highest tendon length, you get slightly lateral to the center, and you go up all the way. And then final step is the tendon cutter. But again, as shown, you can do this procedure very well with an open incision without any special instrumentation. As I said, the technique is exactly the same. The only downside is the cosmesis, but the clinical outcome, I think, as Deepak has shown, is excellent, even with the big incision. And I think the advantage of the quad tendon over the hamstrings is really that you do not need any fixation here on the patella. So here you see the absorbable sutures, and you see that it's a nice flat graft, which is really approximating the shape of a natural MPFL. Crack of sutures, resorbable, and then you measure the diameter, so you know your drill hole size. It's about 6 to 7 millimeter. Then you prepare the medial aspect of the patella, and you prepare the graft down about 1.5 centimeter. Be very careful not to strip it off. Here you prepare the medial side of the patella. You make a cut directly there, and then you undermine the tissue. And it's especially in the young patients, a very good tissue, and it gives you enough strength to suture the graft on the edge there. When you find your plane to diverge the graft, here you see the undermining of the tissue. Use an elevator. Here it's passed underneath. It's diverged 90 degrees and then passed underneath this tissue. It gives you a good fixation. Now it's fixed with 2 sutures here on the edge to really spread out the graft very widely on the supermedial aspect of the patella. You can use 2 resorbable sutures because you get a very quick graft healing. You have lots of area and bony area for the graft to heal to. So fixation is done on the patella. And you can see now you get a strong fixation here. And then you do the same technique as you would do for hamstrings. You palpate the adductor tubercle. You look with the image intensifier for the right position. Then you make your soft tissue tunnel and your drill hole. We always use an image intensifier for this procedure to look for the right position. And then you drill. As again an adult, we use a screw, or you can use just an anchor fixation if you do use an anchor, you have to make a slightly bigger incision in order to prepare your insertion site a little bit better. Here you see the right entry point. You over drill it with the appropriate reamer, which is normally about 6 to 7 millimeter. And then you pass a passing suture with a clamp. You retrieve your graft. Here you see the appropriate length. Now it's important before you pull in the graft, if you make a small incision, put your nitinol wire, as you will see, for the screw in the tunnel in order not to lose the hole. It's very difficult to find, especially before you pull the pin through. Put your nitinol wire for the screw. Then you pull in the graft. Then you move the knee through full range of motion. It's very important if you feel the MPFL tightening with flexion, your position on the femur may not be correct. This is, I think, the most important problem, so be very careful. The MPFL, if it's placed correctly, should rather loosen with flexion and not tighten with flexion. And then in about 30 degrees of flexion, and with just some aligning the lateral border of the patella, not very hard pulling on the suture, you fix the graft. Okay, we looked at this biomechanically because people were always concerned that it's actually a weak link on graft fixation on the patella. So we looked at this, and when we look at the natural MPFL, you see the natural MPFL has a very low stiffness, and it has an ultimate load to failure of about 200 Newton. When you look at all the different grafts, you see, of course, seminosus has a much higher load to failure, but also has a much higher stiffness. So we looked at this, took 13 fresh frozen cadaver and looked at the biomechanical characteristics of the natural MPFL, and then we reconstructed the MPFL with a strip of patella tendon and looked at it again. And what you could see when you compare the stiffness of the native MPFL to the stiffness of the quad tendon graft, no significant difference. The maximum load to failure only with the two sutures. And as I have to say, these are old cadavers. So in a young patient, you have much better tissue quality, so your maximum load to failure will be even higher. But even here, you see that they superseded the maximum load to failure of natural MPFL. What's interesting to see, and in the same laboratory, they did the same similar study using a hamstring graft, and what you could see that the stiffness of this graft is about 3 times as high as the stiffness of the quad tendon graft, and also respectively of the stiffness of the native MPFL. This is just a small series. We published a bigger series just recently. It's just a small series of our clinical results. 23 patients had surgery, was one of the first consecutive series. 24 months follow-up. You see clinical results. I think what we can say, clinical results about the same to the published literature with the hamstrings. But what we do see is we see a lower complication rate compared to what has been published with the hamstring, with respect of having no risk of patellar fracture and having less risk of stiffness and flexion contracture, as it looks like you see VAS over the years. So in conclusion, I think quad tendon is a very good alternative to the most commonly used hamstrings. Maybe in India it's different, since this technique came from India. Maybe quad tendon is used much more frequently in India. I don't know, but you may tell me. We are very happy that the quad tendon avoids any tunnel screw and anchors in the patella. I think this is the biggest risk, and we have seen some bad fractures there. And the most important thing for us is you can safely use it in children, but just don't use a screw on the femur. It's also good to always have a second choice, because if something fails, you need a revision graft. So it's always good if you have existing bone tunnels in the patella. It's a good solution, but so it's always good to have a second choice for this. It may have some biomechanical advantage. Of course, the clinical merit of Quadrin has been proven with longer follow-up, but I think, as I said, Deepak Goyal has actually had quite a large series over many years. So I think you have proven that the open technique works, and I think the minimal invasive technique just have the cosmetic advantages, but clinically, I think there shouldn't be any difference. Thank you very much.
Thank you so much, Dr. Fink, for this lovely presentation. Couple of questions coming through. I know Dr. Anshu has a question, but I'll start off with the first question. You showed in your technique that you used resorbable sutures and not non-resorbable sutures. Why is that?
Well, initially we used non-resorbable sutures. Actually, one reason is the knot can be a little bit protruding. If you have a big knot right on the edge of the patella, if you have a skinny patient, you can feel the knot. And I do not think from the healing part, as we see clinically, you do not need it, because it will heal very quickly. And I think you do not need it. But the major reason was to have a smaller knot and not a knot that's persisting there.
Okay, there's another question for Dr. Christian Hoser. And the question for him is that, can you please elaborate how you use suspensory fixation device with the quad tendon that you've harvested? So how do you prepare the suspensory device on the bone plug?
We use a number 2 fiber wire in a double loop through 1 or 2 holes in the bone plug. So if the bone plug is very robust, then 1 hole is good. Makes it a little bit more difficult to pass the second stitch fiber wire, the second loop through it. If the bone plug is a little bit more delicate, then you make and this is, we think important, a 1.5 millimeter hole. Don't make it 2 millimeter hole. Make it a 1.5 millimeter hole in the bone plug. Then you are safe. We will not weaken the bone plug massively. And then if you pull it in, maybe that's also something different than to a soft tissue graft. In a soft tissue graft, you have a strong buoy on the lateral side of the femur to pull it in. And you will always be able to pull it in. If you have a bone plug, you need to, as you mentioned with the PCL, you need to navigate it around or through the tunnels. And it's more a question of be aware where it can be stuck and push it with your probe, as opposed to just pull it in like very hard.
So how do you prepare, or how do you decide the length of the loop? So that's the other question that's come in. Yeah.
Yeah.
Are you using a fixed suspensory device? Are you using an adjustable suspensory device? And in the slide that you showed, you prepared your own suspensory device. So how do you
So the suspensory device is a commercially available endo button of from any company. And then we connect the endo button to the bone plug with a number 2 fiber wire. And we are believers in non-adjustable looping.
So you get rid of the loop that comes with the device.
Yeah, we buy one without the loop. We buy one without the loop. Yeah.
Okay.
We're not rich enough to cut away this expensive prefabricated loop.
Another question that's come up several times is that you've made your incision, you've harvested the quad tendon. How do you close the most proximal part? Because you're looking through a transverse incision, the proximal part is far away. How do you actually see it? How do you close it? What's the trick?
Now, seeing is not the problem. If you lift up with a long Langenbrecht retractor, really 10, 12 centimeters long, seeing is not the problem. And then you have to bring out the shoulder surgeon in yourself and bringing a sliding knot, then you can close it. You can also use the endoscope to visualize it, and you can do it like a shoulder surgeon and make knots up there, sort of endoscopically supported. And that's not very difficult for people that are used to doing this.
have you seen any difference in the tunnel dilatation rates if you've used a suspensory device or a screw on the bone plug side?
On the bone plug side, you do not get any tunnel enlargement.
Okay.
The bone plug heals in there within 4 weeks. But we do use soft tissue quadriceps tendon as well. And maybe I hand over to Christian Fink about the tunnel widening with quadriceps tendon.
Actually, we looked into this recently by doing some sequential MRIs comparing bone block and no bone block, because it's always a question in the primary, do you need the bone block? And what you can see, I think bone block is the gold standard. It gives you the quickest bone tendon healing. There's no doubt about this. But if you use it with this periosteum flap, we haven't certainly not seen any tunnel enlargement. So this was the big, maybe the healing procedure, the healing bone healing is certainly slightly slower than with the bone block, but we have not experienced any tunnel enlargement like we used to see it from the hamstring graft. And I think another advantage here, if you use a squared tunnel, which gives you more tendon bone contact, this is maybe the biological advantage of this. This is even better, but I think these are minor things we talk about, but the tunnel enlargement has not been the problem we have experienced with hamstrings before.
Okay. So Arubugam, I think you're a great BTB harvester and user. Probably you should switch to rectangular tunnels for your femoral side. That will be definitely beneficial because you do a lot of BTB, isn't it?
Yes, definitely. I will try.
Yeah, definitely.
Actually,
sorry.
We started this technique with rectangular bone tunnels. We started for BTB because it was, to me, it was always, I liked the graft, but the harvest side morbidity was always a concern of me. So I thought just harvest a smaller bone block. And I looked at this patellar tendon once and I just thought we are just using this huge bone block to fill up a round tunnel. It has nothing to do with tendon insertion. So make the bone blocks smaller and just make the tunnel fitting the tendon, then rather the opposite. So this was actually, we completely started with the rectangular with the patellar tendon and then later on moved to the quad tendon.
Okay, Anshu, you have a question? You wanted
my question is for Dr. Fink. So your patient with an ACL tear is ready, all prepped up for surgery. You have scrubbed up and come, and you realize that your cord harvester is just not there. It's not to be found. So where would your allegiance lie? Would you go ahead, do a mini open cord harvest, or would you switch to a hamstring harvest? And the patient is not cosmesis sensitive.
I would definitely be, if I have the patient, I would not rely on the instrumentation. I would definitely do an open harvest. I would not hesitate to go for the same graft, and we can do this. And I think it should not be the instruments should not make your choice of the graft. So they're just a helper, but they are not absolutely necessary. So I think the graft makes a difference. I would not, if I have decided for a quad tendon graft, I would not change my procedure just because not having the instrumentation.
Lovely. So we have, I think, another couple of more questions. How do you choose the screw diameter for a femur or tibia of the quad tendon? Does it change if you decide to use a metal screw or a PEEK or a bio screw? How do you choose the screw diameter?
No, I'm not a fan of oversizing. So as I said, I do not use a screw, or we both do not use a screw interarticularly. We use a screw on the tibia. We are not oversizing it. We are using it in the same size as the tunnel diameter, but we always do a hybrid fixation. So we always use a bone bridge fixation or a post fixation additionally to the screws. You're not rely on pure screw fixation, but I do not like oversizing screws. It's always, regardless of the screw, it's always the same diameter as the tunnel.
So there's a question on PCL, which is when you're preparing a double bundle, do you make a coronal or a sagittal incision in the quads? So I prefer to do a coronal incision. Any preference from both of you, whether you like to sort of split the quad tendon in the coronal plane or in the sagittal plane?
I have to say that we use the quad tendon differently to you.
Okay.
We use the bone block on the femur. We use a flat bone block, so we use a flat bone block. I like to use the bone block for the PCL because it gives you some additional length. But we use a flat bone block, which gives you covers a little bit more of the insertion on the femur, and the round tunnel on the tibia. So our bone block is always on the femur. Because it's flat, it's easier to get it around the corner through a round tunnel. And then we fix the same fixation with the button on the femur. So I have to say I haven't done a double bundle construct, but I like it. I like your presentation. So maybe we change.
There's one more technical question that has come up, is that we're using the tendinous portion for a primary ACL on the tibia. So why do we need to make a rectangular slot on the tibial side? Why do we need to use the rasp? Why can we not just make a circular tunnel? And if you're making a rectangular rasp, and when you drill 2 K-wires to put the rasp in, is there a chance of causing a fracture because you're trying to bang it in?
Yes, you're hitting some very good points. First of all, I think the advantage of a square tunnel on the tibia is not as big as on the femur. I think you can very well use a round tunnel on the tibia, and then you put the screw in. I think you get this very similar insertion side. The only advantage here is that you have, again, if you use a square tunnel, you have more bone tendon contact, which is probably gives you a better healing, as we know from some experimental studies. If you have a more tendon contact and you have a lower diffusion length, you get a quicker healing. But otherwise, you can very safely drill a round tunnel. The risk of fracture, absolutely. You have to be very careful if you use a dilator on the tibia, because the bone hardens when you get proximal to the joint. So it hardens getting toward the eminence. So you have to be really careful. It's not like the classic orthopedic force. You should be very gentle when you put up your dilator. You be very careful that you have the right orientation, that you're not getting oblique to your prior drills. So if you do this, it's more gentle. And I will say, yeah, on the tibia, you can very safely use a round tunnel. If you have a very tight notch, we think that the square tunnel gives you an advantage.
Okay. Any questions from the panel? Anyone has any more questions? Christian, you want to add a comment on that? Do you want to add?
May I ask you to repeat the question, please?
Yeah, the only concern was that I think this has come up a couple of times. Is there any disadvantage of using a round tunnel with a rectangular graft? So I don't have the rasp to make a rectangular tunnel, but I've harvested a quad tendon with a bone plug. Yes. What happens if I put it in a round tunnel? Should I then be using a screw, or can I still use a suspensory device?
I may tell you a secret, Sachin. If I harvest the bone plug on the femur, and I see that I've harvested not the perfectly small in-depth bone plug, which happens, so it would be a lot of work for the assistant to nibble away the bone, I may say to the nurse, today we drill it round on the femur. So I think this is, with the bone plug on the femur, it's not a problem of any volume, meaning you create a defect or so. But what we do then, when we pull in the graft, we very carefully look that the rotation of the graft is similar to what we would do with rectangular tunnels, that it really rotates in, and you can do that with a bone plug. You can help the graft rotate in correctly, as opposed to with a semitendinosus, you cannot do that. I've not found an option to really be able to rotate the graft while pulling. When you're in 90 degrees, you should rotate it by some 90. If you're in 90 degrees of knee flexion, you should rotate the graft. So you can do a round tunnel with a round quad tendon bone plug as well.
Okay, so we have a very sort of prolific BTB user on our panel. That's Dr. Arumugam. So Aru, do you also rotate your graft when you use a BTB and you fixed it? Do you rotate your graft before fixing it on the tibia?
No, not usually, unless you end up with the graft tunnel length mismatch. Then I rotate at the tibial end to shorten the graft. Otherwise, I don't rotate the graft.
Okay, one more technical question. What is the minimum and maximum dimension of the rectangular bone plug that we should do?
Yeah, our
Width,
instrument.
width, height, and length.
So the length is, I think the maximum should be less than 20 millimeters. Don't cut into the proximal patella more than 20 millimeters. You don't need to, and you weaken the patella. The width, 10 millimeters in width is possible. Then it depends on the size of the patient. So obviously it's something that has to be in accordance with the size of the patient. And the width is 11, maybe 12 is something that is the limit to the upper limit of a width of a bone plug, also depending on the size of the patella. But that's what is used in our hands. For the knife used for the tendon, it's a 12 millimeter knife. That's the biggest one that we have.
Okay, perfect. Any more questions? Any comments? Yeah, Parag?
So no more questions, but I think this was an excellent webinar. We want to thank both the Christians. You did a great job. And I think the quadriceps is a good tendon to fall back on, and you very eloquently showed us the nuances of using the quadriceps tendon. So my last question to both of you is, do you always use a quadriceps tendon in a primary ACL reconstruction, or is it another tendon you fall back on? So in your primary ACL reconstructions,
are you 100% quad tendon?
No, not 100%. As you say, it's really, I think ACL surgery is an individualized surgery, and it should never be 100%. There are always reasons why you shouldn't do.
So what's your choice? Second, what's the option then? What are your other graft options?
It's okay. So if the patient comes in and has an ACL surgery on the other side, for example, he has a hamstring 5 years ago, is perfectly happy, I would never use a different graft. I would give him exactly the same graft. So I don't like to change graft. If you have a professional soccer player who come in, they ask for a patella tendon because everybody wants a patella tendon, the coach, everybody, I would not argue. I think there's no reason to me not to do a patella tendon, especially in these high level athletes. I think it's perfect. He does not have to kneel. Maybe if he's got some patella pain, it's a little harder, but it's a good graft. And I would, so it's definitely, there are reasons why you would do this. There are some clear reasons for us for quad tendon. It's a medial instability. If somebody has an additional medial instability, we do not like to harvest the hamstrings, for example. It's clear if somebody has a kneeling occupation, I would not use a patella tendon. If somebody has to kneel on it. In a professional climber, for example, professional indoor climber, I would not use the hamstrings because they renew the hamstrings much more than the extensors. So there are some special reasons. But generally, I think, as you saw from our data, if sports activity is not the big issue and they are less active and lower activity levels, I think you can use any graft. You're very safe with hamstrings. When it comes to higher activity, then I think we have to be careful.
So Dr. Hoser, any closing comments from you? So, and then we close with Fiona.
I have one question.
Okay, Sandeep, you can come with a question, yes, before we...
A question to both of you. Have you ever had a premature amputation of quadriceps while harvesting?
Okay. So a technical question again. What happens, or have you had a premature amputation of your graft? And if it does, what happens next?
Of course. Yeah. Maybe some surgeons get louder and some surgeons get very calm in this situation. Yeah, we had that. The dangerous part is when you slide in the tendon cutter. When you slide in the tendon cutter, you have to extend the leg a little bit so that the tendon tension is reduced and you can slide it up because the lower part is obviously sharp. And if you have too much tension, then you can cut into your tendon and then you have a premature amputation. And then we did, I think, semitendinosus in the few cases. You're safe with a semi then. It's a little bit harder to explain to the patient after surgery though.
Okay.
Thank you.
Okay. So I think we'd like to thank both our speakers today. They've been absolutely excellent, and I think they had a large volume of knowledge to share for all of us. I think to try and get these two giants of quad tendon on the same platform was a giant task, but just one phone call, and it was absolutely a quick yes from both of them. Probably it's very heartening to know that we have 4,000 surgeons who have attended this webinar, and we'll know the real numbers on YouTube afterwards. But anywhere in excess of 4,000 has been a viewership, which goes to show the kind of popularity that both of you gentlemen do enjoy. So thank you very much from the Pune knee course organizing team to both of you, Professor Fink and Dr. Hoser, as well as all our attendees, and Dr. Ashok Sham of IORG for hosting it up. And follow us, all our surgeons. We're back next Saturday at 7 p.m. We won't make a mistake, 7 p.m. India time. And we have our magician, Dr. Ronald von Heerwaarden, who is no stranger to all of us in India. And he's going to be taking a 2-hour masterclass on advanced planning in complex osteotomies, slope corrections in ligament laxities, rotational osteotomies for axial plane deformities, and intra-articular osteotomies for malunited tibial fractures. So do join us next Saturday, 7 p.m. We won't make a mistake, as I said, and we'll hope to have you join us with none other than our very good friend Ronald Heerwaarden, who is probably the magician of the osteotomies. And thank you once again, Professor Fink and Dr. Hoser. And over to you, Parag, to make last closing comments before this very successful webinar closes.
I think it was excellent, a lot of learning. And even though we kind of delayed by an hour, we still
So Parag, have we lost you there?
Yeah, I think we lost.
So we just lost Parag there. So I apologize on his behalf, and thank you so very much to all of you to join us today. Thank you, and hope to see you again.
Thank you.
Next
Thank you.
weekend.
Thank you.
Thank you.
Bye-bye.
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 Bye.
Thank you.
Bye.